first one.
Perfect. Okay. So we have, again, 3 of our alums. So first is Pamela, and I'm not going to say too much and read everything on the slide to you, since a lot of this is what she's going to be talking about. But I will say, I love these pictures. Liz pulled together some pictures at the last minute. So obviously we have a very professional present day Pamela, but the picture on the right, a group of us did the Twinkie run in Gallup Park several years ago, and hopefully there'll be a chance for us all to do some activities like that in the future. So that's Pamela with Peter on a very full belly of lots and lots of Twinkies after the 5K. And then the bottom picture was part of a class that a number of us took part in, where we spent about a week in DC learning about healthcare policy and how policy decisions were made. And so Pamela can talk a little bit about that experience. Our second speaker, Bill, is again here, very professional. Bill, I wish I had gotten your new pictures. Maybe you can share a screen photo of your latest big exciting news. But we have Bill, very, very professional here in his new role, but also you can see, if you can make out the picture, Bill's here down below with Pamela. This is at one of the Florida hotels where everybody got to give some conference presentations and take a little bit of a break, and then showing off his, Bill was usually one of the most stylishly dressed folks at CHEPS, but he sort of influenced the rest of the gang. So we have a lot of mismatched plaids here again at one of our conference presentations, and we'll look forward to hearing about Bill's work, Kaiser Permanente, and then Joe, who's going to actually start us off talking a little bit about the program. And again, going back to some of our earliest meetings, it makes me very nostalgic, Joe, to see the whiteboard. That's one of the things that those of us at CHEPS are really missing, is just being able to cover boards from floor to ceiling with notes, and being able to be together in a big group. And again, the chance, I think this was actually right before meeting Merrill Bonder for some ice cream at one of our Informs conferences. So we're kind of highlighting here both some of the strengths of the program, but also some of the things that we're missing most in terms of students being able to be together and brainstorming, in terms of our chances to travel and go to conferences. And so I'm going to turn it over to you, Joe, and ask you to start off by just giving people who don't have this background a little bit of information about the program. And then if you can talk about your experience and hand it off to everybody else, and we'll kind of make it up as we go from there.
Yeah, sounds good. Thanks, Amy. And Pamela and I were on before Bill, so we deferred any technical questions over to Bill. So good job, Bill. So I'm Joe East. I was at CHEPS back from 2012 to 2014. I'm currently out in Portland, Maine as the Director of Patient Access and Flow. And for those who don't know, CHEPS is a concentration program within the IOE program at U of M. It is, what does it stand for? Healthcare Engineering and Patient Safety. The big focus of it obviously is taking the engineering skills and layering on top the healthcare application with that. And so it involves doing some extra healthcare courses, and then particularly doing a year-long research project with Amy and a lot of the stakeholders and faculty at both the engineering school as well as the hospital. So I think the biggest benefits of it that at least I found come from it, where it helps a lot of the students that take it have a greater awareness of the way that IOE tools and technologies and statistical processes and the critical thinking skills, how that can be applied and benefit healthcare. Second one that I think is really key is it helps us have the confidence and knowledge that we know the tools to use, we know the healthcare language, we know how to go up and talk to a doctor or a nurse or an administrator and say, here's how we can add value into your work. And certainly that's one of the primary reasons that we're all are interested in this, is we might be interested in healthcare for many different reasons, but ultimately we want to be able to get a really good job after school, and we want to be able to do that in a field that has a high impact. And so certainly healthcare is one of those highest impact areas that we're able to work on now, especially with our engineering skills. And then the third one, as everybody knows, is the building that network of colleagues and friends that you meet at CHEPS, and you spend a year together, a couple of years, and you draw on that throughout the rest of your career. And so whether it's professionally and you have a project and you're looking for help with projects, or whether you're looking to catch up, that friends that you make in HEPS is really incredibly important and valuable. So that's my 30-second conversation of what I think HEPS is. Pamela, Bill, anything to add in? I got it pretty good.
Yeah, I think you covered it pretty good, Joe. And fun fact, then Pam and I, we saw each other on a highway in Colorado this February when we go skiing. We didn't really get to talk, but we wave at each other because we were both texting and we were like, oh yeah, I'm in Colorado too. But you know, that's another form of your reunion on the highway.
Turns out that the Michigan Network alumni spreads pretty widely. So even on random concerts, you can definitely find people.
Yeah.
So our next part was we're talking about the program and what we had. So I was the reason I wanted to do HEPS as a concentration program was I did the dual master's program with the industrial engineering as well as health management and policy with the School of Public Health. And so I was really focused on doing both parts. And so the engineering side was really that focus of how do I get the right tools. I did biology in undergrad, and so I wanted to get much more technical and say, how do I know the technical tools to say if there's a healthcare problem, how do I be able to develop better tools and develop better solutions to improve the healthcare operations. And then on the healthcare side with the School of Public Health is really learning about that content and that subject matter to say if, what are the right areas to focus on, what are the areas of need, and then how do you take those tools and techniques and actually implement them in lead projects and lead teams. And so what drew me into healthcare initially was it's really this high impact field, right? So industrial engineering has been applied in a whole lot of the manufacturing and aviation and logistics areas in many different industries throughout the last 50, 60, 70 years. And it really is fairly new to healthcare. And it presents a couple opportunities. One, healthcare helps, obviously it has a huge impact on people's lives, the patients' lives. And so the work we do can have a pretty quick, relevant benefit to many, many thousands of lives. And that's different and novel in some ways than a lot of the other fields that we can use engineering in, where there's certainly those same benefits that can occur, but it might be a little bit less direct as it is in healthcare. The second piece was can have huge financial impacts. And so, healthcare, depending on how you look at it, is around 18% of our GDP. So that's trillions and trillions of dollars that we're spending every year in this country, and certainly much more around the world as well. And so if we're able to come and bring, sort of our analytical mindsets and our critical thinking skills to make more optimized systems and solutions, we can have a huge financial impact for either the organization that we're working for, the community as a whole, if we're able to decrease healthcare costs, and certainly as more and more health insurance becomes high deductible plans that patients are paying more of those costs, it has a big impact for them as well. And third piece is that there's a lot of people that work in healthcare, and it's by nature a service industry, and we're never gonna automate a whole lot of the work that we do in healthcare. And so with plus minus 15 million people in this country that work in healthcare, if we're able to develop better systems that make it easier for those clinicians to do their job, then that can improve their work-life balance, that can improve their engagement at work, and make their jobs and their lives better. And so that value equation for why this industry is really good and valuable was what drew me into this field initially. And certainly going through HEPS gave me those skills to be able to work really well on that. And after I graduated and sort of hit the ground running. So in my time in HEPS, I worked on a pediatric asthma project. So I don't think that's going now, but it was a project where we worked with Michelle Macy and a couple of the other ED physicians at U of M, looking at pediatric patients with asthma exacerbations and that flow through the emergency department and hospital. And the work that we did was saying, can we develop a better rounding schedule, develop more optimal solutions to say that we could get patients through and shorten their length of stay so that they would have to spend less time in the hospital, which would benefit them and it would benefit the patient, obviously, to get them out quicker when they didn't need to be there longer, and then benefit the hospital, increase capacity in their ED and inpatient units. And then the other project I did was looking at clinical trials research to say if U of M, they have the couple hundred trials at any one time, and they have a couple thousand patients that are interested potentially in trials, is there a way to optimally match the patients and their criteria to the trials and that work so that we can have a higher success rate in filling clinical trials? And that obviously can help to have more recruitment into trials and higher success rates, which can help those succeed. And so both those areas help partially to say what are some good technical tools that I can learn and apply, but also how do you learn all those soft skills? How do you talk to doctors? How do you talk to nurses? How do you take a fairly vague problem that a clinician comes to us with and really focus that conversation in and translate it into either a technical problem from our respect, or if the doctors are thinking one thing and the administrators are thinking another, how do you sort of cross that language to say, not only can we improve patient outcomes and patient care, which the doctors care about, but how do you also improve bed utilization, which, among other things, the administrators care about. And by doing all those together, we can have a higher chance and success rate at implementing good solutions. Yeah, I'm done. That was mine. So that's what I did in HEPS and why I'm sort of working in this field and got interested in the first place. And Pamela, I'm going to toss it over to you.
All right. Well, thank you. Well, I have a slightly different experience of why I got into the program, but I joined back in 2014 and graduated in 15. The reason why I got into healthcare and I joined the HEPS program particularly was because I did a summer research opportunity program in Michigan in 2013, and that was actually the first time that I was exposed to healthcare as an industrial engineer, and got to see what industrial engineers and other type of engineering backgrounds could do in healthcare. During the summer research program, I was working with a professor in Michigan, and I also got to go to a healthcare conference which was all about process improvement. And I thought it was, I was really surprised. I didn't know about this. I was very excited to learn more about it. I thought it was super impactful, and I was really looking for just my next step. I didn't know what I wanted to do. I wasn't really interested in manufacturing. Growing up, I always said that I wanted to be a doctor. I really didn't know what I was talking about, but I thought this was a great way to work in the healthcare field without having to particularly have to be a clinical person. So yeah, that's why I applied to your program. I got accepted. Overall, it was a great experience and a great stepping stone for me to continue in this career path. When I joined, I was assigned to an ongoing effort in the cancer center. So we were working with, we were focused on improving the experience of patients receiving outpatient chemotherapy in the University of Michigan Cancer Center. We knew that process had a lot of delays and a lot of areas of improvement where we could just minimize some of the inefficiencies that we were seeing. So there were several efforts happening when I joined this project. One was a scheduling optimization model to reduce the patient wait times in the infusion center. There was another one that was about, it was a simulation analysis on the phlebotomy area. So how could we expedite not expedite, but just improve that process, because it was the first step in the process that if it was delayed, it kind of impacted the whole patient experience the rest of the day. That was the one that I was mostly involved. And then by the end of my program, we were also starting to see develop a simulation analysis on how to mix chemotherapy drugs ahead of time to kind of be more proactive and just not have to wait for the patient to get into the hospital to start mixing those drugs. I know that became, Amy, correct me if I'm wrong, but I think that was Donald's dissertation after I left the program.
I literally just typed that into the chat. And just a reminder, Pamela, that there's another way that you could become a doctor, just like Donald did. We'd be happy to have you back. Just saying. I'll mute now.
All right. Thanks, Amy. Thanks for reminding me that. But yeah, so that was my experience. Those were some of the projects that I was working on. At the same time, I also had an opportunity to work as a part-time student assistant to a project manager in the cancer center. I think that was great. That was my first exposure to project management. I got to see how like projects were run in the hospital, and a lot of what I was doing was data cleaning, working with EMR data, just working on data visualization and the analysis and interpretation of that data, which I thought was like a great experience and learning experience for me, because it was really applicable to what I did after I graduated, and I'll get to it later today. But yeah, in conclusion, I think that the CHEPS programs was great. Similarly to what Joe was saying, I think I learned a lot. One, about the healthcare system. I didn't have a previous background on that. So this was the way that I got to learn more about healthcare, but also experience this hospital culture, which I think was a great opportunity, because it is very different from other just areas, and just knowing how to speak to clinical folks was really helpful, and just in general, just being able to analyze healthcare data and interpret that and present it, and just some of the project management skills that we gained through the program were great. So yeah. What about you, Bill? What was your experience?
Well, you guys already covered the most important talking points, so I don't have to add too much. But I would like to say I also started the program just like Joe. So Joe is kind of the grandfather of all these dual degree programs. So I appreciate and basically copied his curriculum as well. It was very nice to have a pioneer there as a mentor. And well, my story kind of started back in undergrad as well. I met Amy at one of the Informs conference when I was presenting my senior capstone project back in undergrad, and Amy was there as the session chair, so she was like happy to see my presentation, was wondering if I was interested to join CHEPS, and me being naive and young, having a job offering consulting, I was like, well, no, Amy, I would like to go into consulting, and that was probably a very dumb choice. And then I joined consulting, and 2 years later, I find myself feeling pretty insufficient in a way that I feel like I was working with a lot of hospital systems and doctors and nurse and IT professionals. They have a lot of interest in knowing the data, which I can somewhat provide that insights, but I don't speak the same language, and I really don't think I understand the big picture in that. And then I was only seeing a very small piece of it. So that's the time I call Amy back again, say, hey, is that offer still on the table to come back for a graduate degree? I think that's really the time I realized I need to, number one, understand the industry better, and number two, kind of get a better understanding of the operations side with my kind of background in industrial engineering and continue on that route. So I kind of trying to achieve both goals by doing the dual degree program, which really complements pretty well, as Joe mentioned. You understand the bigger picture from the business, the population, the policy side of stuff from a public health perspective, but also from operationally, like you get this tremendous opportunity to working top 10 health systems on campus as a student consultant, learning from the technical knowledge in class from the top professors, but also applying it right away in the project. So in terms of my project experience, I worked kind of help conclude some of the project work Joe mentioned in the pediatrics ED in the Mott's Hospital with their potential expansion of the observation unit. So a lot of modeling simulation over there. And then I worked on, probably the longest project I worked on was the instrument, the surgical instrument project with the OR team. And it was being really eye-opening, working with Jim and Amy and a whole bunch of people on the team together from different aspects, from modeling, from data analytics, and then truly going into the OR to observe a lot of very advanced surgery. So really helped me to understand how to work interdisciplinary team and communicate to the clinicians, as Pam mentioned, as very key skills for you to bring forward into future career as well. So it's been a tremendous opportunity for me, definitely. Happy I made the right choice and somewhat made it the work for the 2 degrees at the same time. So it was a great experience at CHEPS and definitely enjoyed it while I was there.
So maybe we can switch now and go in reverse order, since Bill's already unmuted, and talk a little bit about your current position. And in particular, I think people are quite interested to hear how your work has unfolded in the past 6 months.
Yeah, absolutely. I'll go first. I see that our question is somewhat separated, so I'll answer the first part, Amy, and then we can do another round about particularly regarding COVID. I'm sure we have pretty interesting discussion and we can compare and contrast. So my current role is the Director of Hospital and Procedural Services. So Kaiser Permanente is an integrated health system which we have the insurance arm, the hospital arm, and then the outpatient medical group arm. So I'm currently director role in the outpatient medical group, and we work very closely with our partners in the other 2 branches. But our system in the Northern California have about 23 different hospitals. So if you imagine a much smaller hospital compared to the Michigan, but many more in the region, that's kind of their model. So I manage about 10 to 12, depending how you decide it, outpatient specialties, the typical ones in gastroenterology, cardiology, pulmonology, sleep medicine, anesthesiology, and stuff like that. I don't want to list all of them, but it's a long list of very various different type of specialties. I'm mostly in charge of their strategic development, financial performances, staffing level, and patient service, as well as the facility and equipment purchase and stuff like that. And I have a team of 10 managers who work with me together, and they are directly in charge of those departments. So it's been an interesting experience getting onboarded this year with everything going on. But from my day-to-day, really, my goal is trying to make the life of all my managers easy. They directly report to me, but I see it as a partnership. I really was just trying to be there to remove the barriers for them. Specifically, one day I could be spending 4 hours developing a scheduling or staffing model. The other day I could be deep diving, doing a financial analysis on their budget to see what can we achieve, how can we achieve our kind of financial savings goal by the end of the quarter, or I could do a service recovery with one of our dissatisfied patient and really find out what is the problem with our process that let them down. So it really kind of varies a lot, but I truly enjoy doing this work. I feel like making a direct impact for our members and patients in this area, making sure they're healthy and hopefully we provide the best service for them. So that's a little bit about my current role. Pam, you want to go next?
Yeah, thank you. I'll go next. So I'm just going to describe a little bit what I did right after I graduated from CHEPS and then where I am now. But I joined UCHealth back in 2016. UCHealth is a hospital system. So we have about 12 hospitals in Colorado and then other clinics in the state. The reason why or how I learned about UCHealth and the role that I first applied to, which was a process improvement consultant data analyst, was actually during a conference that we attended with the CHEPS group. I was presenting and someone in the audience was part of this group. They were looking for additional data analysts, and he also happened to be an IOE alumni from Michigan, so he was excited to bring someone else from his same program, the team. So I ended up applying, I got the role. And the reason why I really enjoyed this first role is because I think it was very highly aligned with my IOE background. I was doing a lot of data analysis and simulation. I was constantly using statistics. I was working on some prediction models for the hospital that focused on capacity, and also some no-show models. I was in that role for 2 years, and then I transitioned into a little bit less technical role and more project management focused role. So I'm currently an innovation project manager, and I work for the Care Innovation Center at UCHealth. And what the Care Innovation Center is, we are a clinical validation sandbox. So what we do is that we partner with digital health companies that are seeking to challenge the status quo of healthcare and just disrupt the way that healthcare is currently delivered to patients. And what we do is we partner with them, we help them co-develop products, we test, we pilot, we optimize or scale in our hospital system, and then 2 other hospital systems as well. Sometimes we invest in these companies too, so there's some investment opportunities. And yeah, our partnerships range from working with startups all the way to multinational organizations. So my current responsibilities range from the business development side of things, so the process of vetting companies, of sometimes even developing RFPs to find companies that could, that have a solution that we're looking for in the system. And then it goes from there all the way to scoping the projects, working with the stakeholders, and just leading all of the implementation efforts. So yeah, I think another thing that I do in my current role is because I have the industrial engineering background, and I'm very process oriented. I help develop a lot of our internal processes as well, and the improvement of those processes when it comes to the approach that we take when we are partnering with these companies, but also how we manage our portfolio and our team capacity. So doing a little bit of just different things in the current role. What about you, Joe? I'll pass it on to you.
So thanks. I'm Director of Access and Flow at Maine Medical Center right now. And so Maine Med is a 640-ish bed hospital out in Portland, Maine. And it's part of an 11 hospital system in sort of central and southern Maine, as well as western New Hampshire. There's sort of 2 sides of my role. One is the daily work, and the other is sort of the leadership long-term work. On the daily side, I help lead the patient placement and transfer center for the organization. And so that's a group of 20-25 clinical and non-clinical staff that coordinate transfers into the hospital. So patients come from all over Maine and New Hampshire and Vermont somewhat to Maine Med for the tertiary care services that we provide here. And so this team helps coordinate those transfers in, and then works on all the bed placement for the hospital. So if you think about the hospital patient flow, and in the simplest sense, you have a census of 600, you have 640 beds, you have 120 admissions every day, you have 120 discharges every day. Sometimes your admissions are higher than your discharges, or vice versa. And a bed is not the same across the hospital, and so there's certain beds that only pediatric patients can be in, certain ones that only cardiac patients can be in, or surgical patients. And then on top of that, you have more facility and nursing and patient requirements, like you could have behavioral patients which have special needs, or bariatric patients which have special needs. And so this group helps keep all that Tetris game working, or the optimization problem working, and does that work every day. And so I help lead that team, and then I also help with sort of daily patient flow challenges. And so if we're tight on ICU beds at any given time, I'm usually involved in those huddles with the nurses and the physicians to say, how do we problem solve and and think up backup plans to make that work. Or if we have really high ED boarding or really high boarding in our post-operative areas, how do we manage that and get the resources, whether they're nursing or whether they're bed resources, to the patients so that we can serve their care needs. And then, so that partners in with the other side of my world, which is looking at all of these resources on a long-term basis to say, how do we improve hospital operations? And that might be, you know, repurposing units if we need to change the patient populations that we have for units, might be identifying shifts in patient populations or patient wait times that we need to address and figure out how to better serve those patients. It also is involved in things like looking at admission workflows and discharge workflows, or looking at environmental services workflows or patient transport, to say all these different teams have impacts on each other and on the patient experience and the patient wait time and clinical outcomes. And there's a lot of research out there that says the longer a patient waits for care, the worse their outcomes are, which is fairly obvious on a simple scale, but it has dramatic impacts for the work that we do every day and the prioritization that we're making. And so I help lead that work to say, how do we optimize our bed capacity so that we're not having too much excess capacity, because that's not a good utilization of resources. But it's also, how do we have the right amount for the work that we need, so we're able to meet the needs of our patients and also increase that volume when appropriate to help improve our financial situation and better serve the community that we're in. So that's that. And if we want, I can flip right into our COVID response. And so obviously last March, our world all changed. Because my world is very much involved in that sort of patient placement, bed capacity, inpatient operations, I was the administrative lead, along with a whole team of physicians and nurses and other service line administrators, to say, how do we change the units in our hospital, and how do we change the nurse staffing to be able to accommodate the expected surge in demand. Maine was pretty lucky that we didn't have a huge spike right away, and we actually avoided a really massive spike all throughout. And so because it's a little more geographically in the corner of the country, so to speak, we were probably 2 or 3 weeks behind a lot of the rest of the country when we, in terms of our sort of COVID volume increase, which gave us a huge important opportunity to plan for it. And I think our organization did really, really well in that. And so we ended up converting probably almost half the hospitals in our unit, have made pretty significant changes in one respect or another, and anything from moving an ICU so that we could have a dedicated COVID ICU to we had to move a bunch of surgical units and medical units to accommodate other moves. And so the COVID response that we had at the time, and we still have now, is that all inpatients that are either positive or suspected for COVID, they're going to be in separate units from all non-COVID patients. And in the early days, it was really, really important because we didn't have a great awareness, a great research across the medical community on how much COVID spreads, or even the way that it spread, really. And so we first prioritized making a bunch of negative pressure rooms so we could keep the virus in as much as we could. And so we took a bunch of neutral pressure rooms and made them negative. And then we looked very carefully at the rate of change for the COVID volumes to say, when do we need to add another COVID ICU? When do we need to add another COVID acute care unit? And with that, we're able to stay ahead of that curve and always sort of have that bed capacity. And then, of course, beds don't do you much good unless you have the staff to staff them. And so the next thing that we really worked on in parallel was that nurse staffing, that physician staffing. And so we quickly, right at the start, we canceled our elective surgical and procedural schedules. So that gave us the bed capacity, and that dropped our census by about 150 patients a day on average. But that also gave us that surgical nursing staff, and particularly the surgical CRNA staff, that were able to, and CRNAs are APP, advanced practice providers, that are often not serving in a direct patient care nursing role. In that respect, they're more closer to physicians in some of their scope of practice. But we're able to take them that work in the ORs typically, and because we weren't doing elective surgeries, we could take a lot of that group and have them help out our ICU nurses. And so that gave us the staff that we needed to help care for patients. And certainly you can't take a nurse that works in an OR most of the day and have them plop in an ICU right away. So there's a lot of this training, a lot of these competencies that involved in these logistical moves. And so we did that for probably a good month or so as we were preparing for the COVID increases and sort of got through the height of it for us in Maine. And then since June, so we've been ramping up our non-COVID volume, and we were slowly increased our elective surgical schedule, elective cath lab and procedural schedule, and we're pretty close to back where we were pre-COVID volumes. And then we've been paring down our units where we had 6 or 7 units that were all COVID, and we've converted half of them back right now. We're planning the next stage moves down. And the way that we're thinking about this is every day we look at our COVID volumes from the previous day and what we have today. And then each week we're looking at that over time to say, how are the volumes changing and what's that rate of change? And we know that we're sometime in the next 6 months or 10 months, we're going to have spikes up either in our ICU population or our acute care. And so we're monitoring how many units so that we're able to have be non-COVID and be able to accommodate those populations, because we see a whole lot of backlog and a whole lot of need in those. And so our acuity of our patient populations overall are up, and our length of stay is up because we put off a lot of the elective surgical procedures for a while. And then even the patients that weren't on a procedural schedule, they might have avoided coming into the emergency department for a while. So the ones that are coming in are sicker, and that makes it more resource intensive. That makes it a longer length of stay, which just exacerbates that capacity challenges that we had pre-COVID. And on top of that, we have to have a couple of units dedicated for COVID. So it's this sort of dance of what's the right decision at this point in time, and how do we make plans far enough out so that we're able to communicate across the organization so that everybody has that sort of awareness and confidence together. And so that's the work that we've been doing the last 6 months, and that'll likely continue. One last point I'll make before I'll toss it back to Bill is that the COVID volumes, almost everything we hear in the news is about the COVID positive patients, which obviously are really important to think about. Operationally in healthcare, we have our positive volumes, and then we have all these patients that are suspected for COVID. And so these are the ones that are coming in through the emergency department that they have clinical indications that they might have COVID, but it also might be flu. It might be almost every other disease known to humans because the symptoms are fairly large range. And so the time that it takes between when we send out that COVID test and the 8 to 24 hours that it takes to get those back, those we have to consider them to be COVID patients. And so we have a whole lot of churn within our COVID units for those. And that makes it a higher number of beds, COVID beds that we need to have, and a higher number of PPE supplies and staff and ventilators and all that kind of stuff that we have right now. But we're really focused on saying, how do we improve that turnaround time for those tests so that we're able to keep those units as low, as least occupied as possible, because that'll help give us the flexibility to be able to care for non-COVID patients quicker. It also helps those patients that, there might be only a 5% chance that if you have a COVID test, that you're actually going to have COVID if you're getting admitted in the hospital. But that time for the rest of that 95% of patients is really stressful. And so we're looking at how do we optimize those workflows to decrease that time and to make best use of our resources. So Bill, I'll toss it over to you.
Great, thank you, Joe. I think that's a perfect compliment. I won't go into too much details in our hospital response since Joe has really went into details about that. It's very interesting to see that even though we haven't talked, but we probably are pulling the same lever exactly. I'm moving my CRNAs from OR to the bedside. We're doing ventilator trainings for a lot of people. We converted the ambulatory surgical center, which is where we do most of our outpatient surgery, since we canceled elective surgery and procedures. They become the ambulatory ICU, which is our extension of our main ICU for the COVID patient. And I think San Jose here, where I'm at, is kind of the first area in the Bay Area being hit the earliest. So we have to figure out a lot of ways to respond to this, where the rest of the region are looking at us, how we respond, and try to see any lessons learned. And I will focus mostly on two parts. One, the technology we're leveraging in terms of changing of the care delivery. And then the second part is how are we doing the screening and then mitigating the social distancing. So as Joe mentioned, like it's important to care about the patients who are tested COVID positive and not in the hospital, and then it's totally a different new way. So for us, we're really encouraging a lot of technology use of telemedicine. I'm sure Pam is going to go into more detail on that, but we have been pushing, which is quite incredibly, from like about 10–15% of video visits used for our physician visits to above 60% across board. And then most of our in-person visit has been replaced either by telephone or video, which is really incredible. We have done a lot of virtual kind of classes for our kind of previous educational classes as well as a group using different online platforms. So that's really amazing as well. So the patient doesn't have to come in, and our providers and nurses and the educators can work remotely as well. And in addition to that, we have, temporarily used a lot of different ventilator type of machines. I manage the pulmonary service line as well as the sleep lab. Those are great tools that could be kind of used as a ventilator, even though they're not normally done so. So it's kind of interesting engineering challenge to retrofit those into ventilators just in case we need those equipment. Same with the PPEs, a lot of the procedure rooms, you have all these PPEs that could be used for COVID care, which we have done. And then in our inpatient world, our doctors and nurses are using a lot of video visit because your family members won't be able to visit in the hospital as often or as many of them. So we have been utilizing the video visit as a three-way conversation with the patient at the bedside, with the nurse, with a doctor in their office, and their family outside at the comfort of their home, really trying to provide that kind of on like a synchronized response and communication, even though they're not physically together. And then sometimes it's really sad. Like we have palliative care patients who are at their dying bed, and then their family can only have one member there, right? So we try to utilize that to really see how can we make their last journey the more respectful and meaningful for them with the technology we have, and how to care about a lot of the patients who could be avoided coming into our hospital. We try to ramp up our in-home care as well to utilize technology to do that function. So that's the kind of a technology piece. And then I see there's some question. We'll probably address the question later in the end. But in terms of the COVID testing and screening, we have done two parts. One, I was actually lucky or unlucky, depending on how you look at it. I was in charge of setting up the COVID drive-through testing for our area, and then I was trying to see if there's any examples. Of course, there's not, because we're the first medical center that have to do it. So it really brings back a lot of good memories of industrial engineering, the queuing theory, like all these different processing flows, traffic patterns, facility planning, all those good stuff. So I was really happy I was involved in that, and I thank my boss for giving me the opportunity and trusting me to design that. So we went from like one kind of a Walmart, Costco tent into 4 Connex building with 2 separate tents with 5 lanes going through, and we're about like any day it could be 500 to 800 per patient tested per day. And then we're right now using a similar model to avoid patient coming into our office for a flu shot. So we have I call it the Sonic model, drive-up flu shot clinic set up as well, which we have 12-car space, each car pulling into it, and then people just stick their hands up and then get their flu shot, get their documentation, 2 minutes, bam, they're gone. So it's really cool to having the opportunity to do that. And then on the surveillance side, we're actively kind of looking into the patients who think they might have some symptoms. And then we have our doctors, as Joe mentioned, a lot of times we have the elective surgery and then different specialty doctors, now they don't have that much work. They become our kind of backup resources for our infectious disease doctors, so they can do these screening virtually, and then they have been trained, and then they are running a surveillance program that's pretty expansive. They are talking about probably 200 patients per day for the follow-up calls to monitor their symptoms and then confirm if they are actually COVID positive or not. That really saved a lot of visits to the emergency room for them and reduce their risk, and also reduce our volume in terms of coming to our hospital for unnecessary testing and stuff like that. And then this is really just a team effort, right? You're talking about having the respiratory therapists working with the doctors, working with the nurses and care managers. They will all work together as a team. It's pretty expansive. And finally, we have recently gone live, I think 2 months ago, I was helping them implement a automatic contact tracing for our internal patients and employees. So we kind of look into the EHR system and then identify all the departments they interacted with during the potential incubation period or the time they could potentially infect other people. And then we send an automatically generated email to all the managers in those departments. You have 24 hours to respond, and then you kind of continue that chain of tracing, right? I think that has been working really well compared to the previous, manual tracing is much harder to complete and much less comprehensive. So this system has done a great job tracing any potential patients who have COVID, inform any other people who might have that as well. So hopefully we can see something like that in a larger scale within our own system as well, hopefully to the entire Bay Area. So those are some of my answers. I think I echo what Joe mentioned. We're probably about 85% back to our normal volume in terms of our procedure and surgery centers. Our hospital census actually higher than our normal month in the summer. We have normally seen a low census during the summertime, but a lot of more people are in the hospital right now because they have delayed care in the first several months of the year. So fingers crossed and we don't see another surge, but if we do, I think we have some experience and skills that we have accumulated and lessons learned, so we should be able to handle that. Back to you, Pam.
Thanks, Bill. All of your projects sounded amazing, by the way. Same to you, Joe. I'm really, really impressed by all the work that you guys have done and just the efforts that you touched. From my experience, I think back in March, our team, as I mentioned, we're focused on innovation. We're project managers, but when we started seeing that, the pandemic was happening and we were starting to realize that numbers and predictions were not looking good. Our team and other projects, teams in the system were asked to refocus and put a lot of the ongoing projects on hold and start to focus just on emergency and preparedness efforts. So our team kind of became the project manager group or project management group that was handling a lot of these COVID initiatives and projects. And some of the things that we were touching were hospital operations. We were looking at lab and testing efforts. We were looking at how to expand our current virtual health infrastructure and the remote patient monitoring programs that we already had and the technology that we already had to implement those into COVID cases, and how could we leverage some of the technology and innovations that we already had to support these efforts. We were also looking at tracking our critical equipment, such as ventilators and PPE. So I think from my team perspective and from my role, I was like all over the place. We were getting requests, and whoever was available and whoever had capacity and could support that project, we were assigned to that. So I touched different things. Initially, I helped set up our incident command center, just supporting with the creation of or our org charts and just tracking the schedules and people that were going to be, part of the incident command center for the regions and for the system. Then I started working on creating a tracking mechanism for all the ventilators that we had in the system. Again, we have 12 hospitals, and we really didn't have a good grasp on how many ventilators we had, where they were, and as we were working on bringing more into the systems, where they were going to be deployed. So I helped just create that basic tracking mechanism, and that started feeding different dashboards and different, just meetings where these dashboards were being reviewed and certain decisions for optimal usage and allocation were being made. I also helped set up a new process in the ED for rapid home oxygen delivery and discharge. So by redesigning our process, we were able to turn around ED vets and discharge patients 4 times faster. The reason we were able to do this was that some of the Medicare and Medicaid guidelines, or just billing guidelines, were relaxed during the pandemic. So that allows us to just think out of the box and just change how we were currently doing some of these processes. And this is kind of funny, but at one point I was also even supporting the supply chain team with just making calls to Mexico City and trying to see if we could do some business with people for to buy more PPE. So because I speak Spanish, they were a lot like, Pam, maybe you can help us. So I was helping with that as well at some point. So as you can see, we were working on a super fast paced, constantly just looking where we could support and bring some of our project management skills to support other teams and just help some of these projects and efforts that were happening just happen faster and more smoothly. And our system was affected in many different ways. As Joe and Bill mentioned, we were also repurposing spaces. We had to pause some of the elective surgeries. So I think a lot of systems, us included, were experiencing some financial losses because we were seeing fewer visits and the processes and patient care costs were a little bit higher. But on the bright side, I think the pandemic really accelerated some of the efforts and plans that we had to expand our virtual health services and our remote patient monitoring technology. So a lot of our focus and attention was on that. So we went from having 90 clinics enrolled in the virtual health center to over 800. And in terms of patients that we're seeing and that were using these services, we went to seeing about 200 daily visits to over 400. I'm gonna repeat those numbers. We went from seeing 400 monthly visits to over 200 daily visits, which was like a huge impact. And over the years, we've been trying to how we can increase that usage of these services and make patients stay at home if they don't need to come to the hospital, use some of these technologies. And because of the pandemic and just the importance that just virtual visits took over this time, we were able to see that increase, which I think was a big impact. And also in terms of remote patient monitoring, I think it was very excited. We've been working with companies that have either stickers or some sort of trackers to monitor different vital signs. And during this time, we've been able to test those technologies and run some just tests on certain patient populations, on our employees. And we've just helped develop that technology even further. So yeah, so those are some of the things that I worked on and that we saw on our, just the impact that we saw on our system over the last few months.
Right, thank you guys. So it's a little bit past 5:30, but I saw that some people were like asking questions and they got their questions like answered in the chat. I think Catherine had a question. Are private payers also signaling equal payment for virtual care? So maybe we can just get that one answered and then we'll end the meeting. Just
I have no idea, actually.
Everyone's time.
Yeah, I'm not sure. I haven't heard that, but I'm also not as close to it in my daily work. Definitely could be, generally speaking, most of the time private payers follow the governmental payers fairly closely, and so I wouldn't be surprised if it happens, but I just haven't heard if it's happening sooner rather than later.
Yeah, I actually happen to know this because as I mentioned, our internal insurance plan, you know, obviously they're going to pay for everything we do. We have an exclusive contract that's a given. But from our study of our competitors in other commercial health plan, they tend to continue to support that because mostly what they're finding, at least for our internal finding and other insurance finding, is that if you do a virtual visit, it's a lot of times is a substitute for in-person visit, which is cheaper than an in-person physician visit. So that essentially you're saving money for the patient and the insurance company. So that's their kind of advantage of doing that going forward. They were not as keen on doing that for telephone visits because a lot of times when you have done a telephone visit, it does not substitute an in-person visit. It will still eventually result in another visit to the doctor's office. So that's just pure additional cost for them. So I think there's a little nuance in the telephone, in the telemedicine reimbursement, but video visit is definitely the priority and the preferred method for sure.
All right, thank you guys so much. I'm so sorry that we didn't have enough time for some more questions, but it was very, very like interesting to hear about all the different types of things that you can do with like HEPS and to see you guys all be so successful. And like, thank you so much for coming back and talking to us. And I'm sure that we all enjoyed it. We're virtual claps for you guys. Thank you so much. Okay, I'm going to end
I'm
the
sure
meeting
like,
now. Go ahead.
Yeah, I'm sure Joe and Pam agree that if you guys all have any questions, we're here to answer your questions, particularly about careers and deciding the careers and what to do afterwards. So I'm sure you all have our emails, but you can also put it in the chat and stuff like that. So thank you for having us.
Echo that. We're happy to stay through a little bit after if folks want to talk, and then happy to connect with anybody afterwards as well.
Likewise, I can stay a little bit longer if anyone has any other questions.
All technical questions got to be all remember.
Yep.
Yeah, I'll make sure to send out your emails to everyone. I know Joe talked to me about like HMP and stuff like that, 'cause that's what I want to do. So yeah, they're very, very nice. But I'll just end the meeting now just because if people feel like awkward about leaving and things like that. But I'll make sure that they have your emails to reach out to you guys.
Sounds good.
All right.
Perfect.
Thank you guys so
Good.
much.
Great. Thank you.
Bye.
Bye.